Okay, so hi everyone. I'm Rebecca Gorges. I'm a postdoc at the U of C, and I'm looking forward to sharing my job market paper with you on the effects of Medicaid managed care on outcomes for the Medicare, Medicaid dually enrolled. So kind of to motivate my research question, I'd like to start with the idea that how to best finance public health care programs is a pressing policy concern, and that policymakers face the trade-off between two competing goals. They want to lower costs while also providing high quality care that results in improved outcomes for program beneficiaries. And there's an ongoing debate about whether both these goals of cost containment and improved outcomes are better met using managed care versus fee-for-service payment systems. Under managed care compared to fee-for-service, health could improve or maybe remain the same if managed care plans steer patients towards higher value services and limit spending on low value services and provide high quality care coordination. However, health could worsen if managed care plans skimp on needed services that beneficiaries require, and then because of the financial incentive they have to maximize profits. And so, this all kind of leads to the question of ultimately which payment model is better for health outcomes. And I think kind of what we know in the broad literature on this subject is that in healthy populations, managed care is able to save money by reducing hospital use without resulting in adverse health outcomes for the people that enroll. But there is some suggestive evidence of poor outcomes for high cost or sicker populations that enroll in managed care. So I'm going to study this kind of broad question in the context of Medicaid and for a specific group of Medicaid enrollees, people that are enrolled in both Medicare and Medicaid dual eligibles. And so this slide just illustrates the increase in Medicaid managed care enrollment among duals over the past several years. It's important to note that healthier groups of Medicaid beneficiaries, such as children and families, have been enrolled in managed care for longer. They were kind of the groups that were included in managed care in the earlier days in the 90s when managed care programs began. But during that time, duals, the elderly and disabled, were specifically excluded from these plans due to challenges inherent in enrolling sicker and expensive populations in managed care, like how to set rates to encourage plan participation and avoid skimping on care for these patients that had the potential to be unprofitable. So now we're in this time period where the Medicaid program is enrolling the elderly and disabled, these sickest, most vulnerable populations into managed care, but there's little evidence as to how this actually affects their health outcomes. So that leads me into the research question that I hope to add some information to. How does this increase in Medicaid managed care affect health outcomes for duals? So what do we know from the literature so far about Medicaid managed care? There's been two reviews that I list here that show really mixed effects of Medicaid managed care on the outcomes of both costs, on access to services, and on quality of care. Most evidence that we have to date is from single state or even smaller area studies of specific health plans and their performance. And we think these mixed results are probably driven because these studies really focus on these smaller groups and that there's a lot of state level policy variation from state to state that might drive differences in how managed care affects outcomes. And then these reviews also note that researchers are limited by data availability. Once a state switches to managed care, fee-for-service claims reflecting utilization are no longer generated. And so that's a big barrier to really understanding the services people use once they're enrolled in a health plan. There have been 2 national studies to date of the effects of Medicaid managed care on a variety of outcomes that also found kind of no effects or mixed results. But both of those studies excluded the elderly and disabled. And so that's kind of still a big gap in this literature as we're enrolling these populations. We don't really have a sense of what's happening to their utilization and outcomes. And so my study provides the first national estimates of the effects of Medicaid managed care on hospital use for duals using individual level claims data from 3 years, 2005, 11, and 12. I mentioned before there's a lot of variation state to state in how these managed care plans are implemented. And so I take a lot of that into account in this study. So I'm able to examine 3 common plan types that duals are enrolled in separately. I look separately at managed long-term care plans or long-term services and support plans compared to risk-based plans that carve out long-term care. And then I'm also able to look at primary care case management plans. I focus on the outcome of hospitalization, which I'm able to observe using fee-for-service Medicare claims. So recall these are duals, and I focus on the folks that are enrolled in traditional Medicare, and Medicare remains the primary payer for hospitalization. So I'm able to see their claims both before and after they enroll in the health plan. And I look at 2 outcomes, the outcome of just any hospitalization, and then I also look at the outcome of potentially avoidable hospitalization using the AHRQ and PQI definitions derived from diagnosis codes. Now, a big challenge to looking at the effects of Medicaid managed care or managed care in general on health outcomes is that there's selection. So, policymakers opt to have managed care in their area, and then also people have to opt in to managed care plans. They may have a choice between fee-for-service or managed care. And so this selection drives my analysis strategy. So I do 2 sets of analyses. In counties where there is mandatory enrollment into Medicaid managed care for duals, I use a difference in differences design. And then in counties where there is voluntary enrollment, so there are plans available, but people can opt to have fee-for-service coverage still, I use an instrumental variables design, and I'll get into the specifics of those throughout the talk. Just very quickly to preview what I find that managed long-term care plans are associated with small increases in hospitalization rates and the rates of potentially avoidable hospitalization. And I find that this is true especially among beneficiaries with 4 or more chronic conditions. So perhaps the sicker people within the pool of duals that I'm looking at, those with 4 or more chronic conditions compared to fewer, seem to bear the brunt of these increased hospitalizations. I find mixed effects mixed results for the effect of comprehensive managed care plans, these plans that carve out long-term care but include some risk-based component. And then I find no effect on hospitalization rates for primary care case management plans. So to jump into the data, I have data from a variety of sources. So I have Medicaid claims, so it's the Medicaid, the MAX data that takes data from all states and is provided by ResDAC. And we have data from 2005, 11, and 12 across all states that provide data those years. And I have an enrollment file so I can see who is enrolled in a managed care plan and their type of plan. I also have county of residence and then all of their fee-for-service claims, including their long-term care claims. I'm able to link at the individual level to the Medicare claims for all of the dual enrolled Medicaid beneficiaries. And from here, I can see their demographics and mortality. We also can look at chronic conditions that are coded in the Medicare data using their chronic conditions data warehouse algorithms. And then we have fee-for-service claims. So I use the MedPAR file to identify hospitalizations and also the diagnosis codes to identify these potentially avoidable hospitalizations. Finally, I've linked in county level data from a variety of sources. So one thing that's important to note about the Medicaid enrollment information on managed care plans is that it's hard to tell in those plan type information that you get in the enrollment file if someone is enrolled in a long-term care plan or a risk-based plan that does not include long-term care. And so what I've done is gone through a bunch of different sources to kind of code up whether long-term care is included in the risk-based plan or not. So I'm able to look at those types of plans separately. I also, from the program information, know whether or not the county has a mandatory or voluntary enrollment policy for that quarter for duals. And then finally, I've linked in some additional variables just to control for the healthcare markets in the county from the area health resource file. So a couple of quick notes before I get into the empirical details. One thing that's important to note is that I'm focusing on duals, and they can be enrolled in fee-for-service or managed care in both the Medicare and Medicaid programs. So there's kind of 4 options for duals with respect to managed care enrollment. And so what I've done, because I'm using fee-for-service claims in Medicare to observe the outcome, I need to restrict to the subgroup of duals that are enrolled in traditional Medicare. And so I exclude the approximately 13% of duals during this time period that are enrolled in a Medicare Advantage plan, so I can observe their hospitalization. And so essentially what I'm doing is comparing people in fee-for-service Medicare and fee-for-service Medicaid, they're my control group, with people that are enrolled in fee-for-service Medicare and then people that are in managed care for their Medicaid. And then I want to tell you a little bit about these plan types, because I do all of my analyses separately by plan type. So I want to convince you that that's important to do. So just to remind you, Medicare pays for medical care. They're the primary payer. And then Medicaid is left to cover long-term care, things like nursing home care and alternatives to nursing home care in the home or community. And then Medicaid also covers Medicare cost sharing, like premiums and deductibles and co-payments. And then other services that aren't covered by Medicare that may be optional for the state to cover in their Medicaid program, like behavioral health or dental. And so what this means is that these different plan types are covering different parts of those Medicaid services. And so I've kind of tried to think conceptually about what I expected to happen when we looked at plan types separately, and I tried to make this graph for you to have a sense of what I was expecting going in and kind of the different incentives that these plans have. So on the x-axis here, I have the financial incentive for the Medicaid health plan to reduce hospital use. And then on the y-axis, I have the ability to reduce hospital use based on what they cover. And so, in the bottom here, we have these primary care case management plans. All these plans do is enroll the beneficiary into a case management program, usually affiliated with a primary care doctor. And then they are supposed to provide some enhanced care coordination services to that beneficiary. But all their Medicaid covered services are still billed fee for service. And so that's why I've placed them down here. They have very little incentive to reduce hospital use because the plan actually isn't responsible for paying for hospital care. And then they have very little ability to reduce hospital use because the plan also isn't paying for any services. They're only covering care coordination. Next, we have these comprehensive managed care plans, is what they're called. But they are these risk-based plans that carve out long-term care. And so they really only cover Medicare cost sharing and care coordination. Now, these plans have a larger incentive to reduce hospital use because now they're paying the Medicare cost sharing portion of hospital care. But they may have very little ability to reduce hospital use because, again, they're a secondary payer for most of what they're covering. And so, it's really kind of up. So they don't really have, they're not providing the primary care, they're not steering people towards long-term care options that might be better for them. And so that means their ability to reduce hospital use is quite low. Finally, we have managed long-term care plans, and these are the most comprehensive because they include the bulk of costs that Medicaid is responsible for duals. And I think these plans have probably the highest ability to reduce hospital use because we might think that if a health plan can provide high quality long-term care, then that could keep people out of the hospital, hopefully. But they may have less of an incentive to reduce hospital use because they are kind of trading off the higher costs of high quality long-term care with just the cost sharing portion of a resulting hospitalization if they provide lower quality long-term care. Okay, So now to get into the empirical strategy, one approach that you could use if you wanted to understand the effects of Medicaid managed care on hospitalization is that you could run an experiment where you have a treatment group that are randomized to have managed care for their Medicaid coverage, a control group that has fee-for-service. However, I don't have the ability to run an experiment, and instead I have an observational study, and so I must account for selection. And like I alluded to before, there's two different types of selection that are going on. The first is that states or counties need to choose to adopt managed care in their Medicaid programs for dual eligibles. And then when enrollment is voluntary, the individual dual eligible needs to sign up to join a health plan. And so I deal with this two different ways based on the enrollment policy in the county. So for mandatory enrollment programs, I use the difference in differences design, where treatment is assigned at the county quarter level, and I compare the treated group are places where there is a mandatory Medicaid managed care program for duals during that time period, and control counties are where there is no Medicaid managed care. And then in counties where there is voluntary enrollment of duals into managed care, I use an instrumental variables approach. Now treatment is assigned at the beneficiary level, beneficiary quarter level, and the instrument that I use is the share of non-dual beneficiaries enrolled in Medicaid managed care by that plan type at the county level. And so I'll get into more about that after I explain the details of the diff and diff design, but I wanted to give you kind of an overview before I jump into the details. So for the underlying assumption of the diff and diff design is parallel trends. So the counterfactual is that in the absence of Medicaid managed care adoption in the county, the treated and controlled counties would have had the same trends in hospital use. And so there's two potential threats to this that I directly address with my study design. So the first is that because treatment here is defined as having a specific type of managed care, so say a long-term care plan in the county with mandatory enrollment, the control group is not having that type of managed care. There could be, to avoid other changes going on in the control group, like the implementation of a different plan type during the study period, the control group is explicitly defined as the 1,200 or so counties that do not have any Medicaid managed care program across any of the types for duals during the study period. The second thing that happens is because I limit the sample to people that have traditional Medicare, so I can see their hospital use, if the composition of the sample changes differentially between counties that adopt Medicaid managed care and counties that don't, that is a problem for the diff and diff design. It violates this assumption. And so I've dealt with this two different ways. In the main results that I'll share with you today, I've used inverse propensity score weighting to make the sample composition look the same throughout the study time period, because I do see that places that have Medicare Advantage expansions also have Medicaid managed care expansions during the study time period. So I deal with that in weighting. I also have a separate set of analyses in the appendix where I exclude counties that have large changes in Medicare Advantage during the study period, but it doesn't really impact my results. They're pretty similar both ways. So I use just a standard difference in differences estimating equation where I have individuals I and county C at time t. I'm looking at the outcome, which is binary if there's a hospitalization or a potentially avoidable hospitalization. I use this indicator for treatment, which is at the county level, saying there is a managed care plan type in that county during that quarter with mandatory enrollment. And then I have county and time fixed effects, and I'm able to control for kind of the limited set of demographics that we have in the claims data. And now to get to the details of the instrumental variables design. So in places where there is voluntary enrollment of duals into managed care, we have this problem where we have underlying characteristics like probably their health that affect both the decision to enroll in managed care and also the outcome of hospital use. And so I have this instrument that I'm calculating from the claims data, which is the share of non-disabled, non-elderly, and non-dual Medicaid enrollees that are enrolled in Medicaid managed care. So, you know, the assumptions in addition to strength, which we can test in the first stage, is that this instrument, the share of non-duals enrolled in managed care, must not be correlated with the confounders, so the characteristics that impact, you know, the individual dual eligible's decision to enroll in the health plan or not. And that's why I derive the instrument from a different population, the non-disabled, non-elderly Medicaid enrollees. And I think that, that it's not unreasonable to assert that this county level enrollment of non-duals, this different population, is unrelated to the health status and the choices of the specific dual eligibles selecting into managed care or fee-for-service Medicaid. Also, the instrument cannot directly impact the outcome. So this county level enrollment rate of managed care among non-duals cannot be directly related to the hospital care that duals are getting. And I think this is also reasonable. I specifically am looking at non-elderly, non-disabled Medicaid beneficiaries to derive the instrument, and they see very different types of providers. These are mostly pregnant women and children that are getting very different care from the disabled and elderly dual eligibles. And so I think that, you know, convergence due to high managed care penetration in the county probably is unlikely when they're seeing very different groups of providers. And they're also hospitalized for different reasons. So to estimate the IV analyses, I use two-stage least squares. This is the standard two-stage least squares equation, where in the first stage, I estimate the individual level managed care enrollment among dual eligibles using this county level instrument of the share of non-duals enrolled in Medicaid managed care. So now to kind of describe the data a little bit more, you can see these are just the standard table 1 of summary statistics at the beneficiary quarter level. I've divided the columns are, you know, the people that are in fee for service versus each of the plan types. So these are the primary care case management, CMC, and then these managed long-term care plans. You can see the age of the sample is probably what you expect when we're thinking of dual eligibles. The average age is around 65. And you can see that it's split pretty evenly between people that are enrolled in Medicare because of their age, they're 65 or older, compared to people that are enrolled in Medicare because of a disability. But you can see that these PCCM enrolled are more likely to be disabled than elderly compared to the other groups. One thing that's important to see from these sample statistics is you can see that that the different plan types are rolled out in different areas. So you can see that the CMC, these risk-based models, both the long-term care plans and the CMC plans, are more common in metropolitan counties. These PCCM plans are more common in more rural areas. And then that also follows through with the demographic characteristics, where we see that the people that remain fee-for-service and enrolled in these PCCM plans are more likely to be white than the people in the more metropolitan areas that enroll in these managed long-term care or comprehensive managed care models. When we think about the health characteristics, so this is kind of the selection that we're worried about, we can see that the share of people with 6 or more chronic conditions is higher in the fee-for-service group and the managed long-term care group than it is for people that are enrolled in the primary care case management or CMC models. And then I've also coded up using the Medicaid claims the share of people using Medicaid long-term care services, and that's definitely highest at half among people that remain fee-for-service. So this kind of suggests that people that stay in fee-for-service, consistent with a lot of other literature, tend to be sicker. When we look at rates of mortality, that also comes through. So mortality rates of 1% in the sample of duals among people that are fee-for-service, so 1% each quarter, relative to about 0.5% of the other groups. And then when we focus on the outcomes that I'll be looking at, the rate of hospitalization and potentially avoidable hospitalization is highest among the fee-for-service group also. Okay, so now I'm going to jump into the results. So these are the results looking at the 2 different plan types where there's mandatory enrollment. So there's very few counties that have a PCCM plan for duals that's mandatory, and so I don't do the diff and diff estimation for that plan type. There's also very few CMC programs that have mandatory enrollment in non-metropolitan counties, and so I also don't do the difference in differences estimation for that subgroup of duals. So what you can see here is that these managed long-term care plans have a coefficient of 0.004, so 0.4 percentage point increase, are associated with a 0.4 percentage point increase in the rate of hospitalization in metropolitan counties. And that 0.04 percentage point off a baseline of 11% of hospitalization is a small increase of about 3% of the average. The sign of the coefficient is the same for metropolitan counties, but the effect is not significant in metropolitan counties. And then when we look at the effect of these plans that don't include long-term care but do cover Medicare cost sharing, we have the same point estimate of 0.4 percentage points. So again, a small increase. This is in the metropolitan counties that have these mandatory CMC plans. These are the effects looking at the outcome of potentially avoidable hospitalization. And so in contrast to the small increases in the rate of hospitalization overall, these mandatory long-term care plans and CMC plans are not associated with changes in the rate of potentially avoidable hospitalization. Now to show you the IV results, to orient you to this table that has a lot of numbers in it, you can see for the outcome of any hospitalization, I report the OLS estimates of the effect of of long-term care plan enrollment, and then next to it is the IV estimates with the first stage F statistic. And you can see that these, consistent with the difference in differences results that showed an increase in hospitalization, I also show an increase in hospitalization in these non-metro counties with a point estimate of 0.03, or a 3 percentage point increase, which is actually a 30% increase in the rate of any hospitalization for these voluntary managed long-term care programs. And similarly, I have increases in the rate of potentially avoidable hospitalization for these managed long-term care programs as well. And these effects are quite large. One way I'm thinking about how to reconcile the differences in magnitudes in these effects is that that the difference in differences effects are average treatment effects for the population when there's mandatory enrollment. And then these effects are a local average treatment effect for the people that that sign up for managed long-term care because of the managed long-term care environment in their county. To contrast this, so these are the IV results for these comprehensive managed care plans that exclude long-term care services. And here I actually find different results. So remember, I showed a small increase using difference in differences for the mandatory counties. Here, using instrumental variables, looking at voluntary programs, we have small decreases in the rate of any hospitalization in non-metro counties, and small decreases in the rate of and decreases in the rate of potentially avoidable hospitalization. So I'm kind of still thinking through why the differences and IV results are different for this plan type, but that's, so I do have mixed findings here. Finally, for the primary care case management plans, you can see that when we use instrumental variables for these voluntary programs, we see really no effect on the rate of any hospitalization in either group of counties, and no effect on the outcome of potentially avoidable hospitalization. And this is perhaps unsurprising because these policies they're not responsible for paying for hospital care, and they're not responsible for paying for any Medicaid covered services besides providing enhanced care coordination. So to summarize my overall results, I find that managed long-term care plans are associated with small increases in hospital use, both in mandatory and voluntary counties. And then there are also small increases in the rate of potentially avoidable hospitalization in voluntary enrollment counties. I find mixed effects for these CMC plans that carve out long-term care. I find a small increase where enrollment is mandatory in overall hospitalization, and a decrease in hospitalization in counties where enrollment is voluntary. And then for primary care case management models, I find basically no effect on enrollment, on hospitalization. In the paper, I do a series of stratifications to try and understand, are there certain groups for whom the effects are largest, or certain groups that drive these results. And I'm just going to show you the effects for these managed long-term care plans here today. The paper has effects for the other plan types, but you can see these are just plots of the coefficients from the difference in differences estimates using stratification. And you can see that, remember, for managed long-term care plans, overall, I had small increases in the rate of any hospitalization, especially in non-metro counties. And you can see that these effects do seem to be driven by these people with 4 or more chronic conditions, both with point estimates that are larger in non-metro and metro counties. And then they're pretty much flat across the board for the effects of potentially avoidable hospitalization, suggesting that the overall findings of small increases are driven by people with more chronic conditions. And then similarly for the IV estimates, although the standard errors get quite large in these metropolitan counties, you can still see a larger point estimate for the people with 4 or more chronic conditions relative to people with 0 to 3. Perhaps also a larger effect for people with using long-term care relative to people that don't use long-term care. And so I think this is the last slide. So to kind of wrap things up, expansions of Medicaid managed care to duals seem to be having different effects on hospital use than for other populations that have been kind of largely the focus of the literature to date. I find that managed long-term care plans are associated with increases in hospitalization and potentially avoidable hospitalization when there's voluntary enrollment, especially among beneficiaries with more chronic conditions. For the risk-based plans that carve out long-term care, I have more mixed results. And then I find no impact of these primary care case management plans on hospitalization rates for duals. There's a couple of policy implications that I'd like to point out. The first is that especially for beneficiaries with high healthcare needs, so among duals who are already disabled or elderly and low income, it looks like we find increased hospitalization among kind of the most vulnerable, these folks with 4 or more chronic conditions in the claims data. And so it's important for states to hold plans accountable for quality, especially among these more vulnerable populations. But there is the important caveat that I'm only looking at one outcome, hospitalization. But if we want to kind of think about, is managed long-term care welfare improving, we need to understand additional outcomes to really get a full picture of whether or not these plans are working for beneficiaries. And I also think that it's important to have this kind of sense of nationally what's happening with Medicaid managed care for duals in light of the new models that are being tested in demonstration projects now that combine Medicare and Medicaid into a single health plan. These demonstrations, because it might give states a better sense of what they should expect, and also the incentives for these health plans when they're only covering Medicaid services are quite different from when they're responsible for the full cost of hospital care. So this study kind of helps shed light on what happens when you capitate just part of the Medicaid services to give them an idea of whether or not they want to adopt some of these newer models that are just being evaluated going forward. So thank you very much for the chance to present, and I'm looking forward to our discussion.
Thanks very much, Rebecca. Can you stop sharing your slides, and Marguerite will then start her slides?
Yes. Okay.
Great. Good morning, everyone. Okay. Thanks so much, Rebecca, for the opportunity to read this paper. I have just kind of four sort of discussion points I want to touch on. So the first one relates to a literature that may be of use to you in reviewing if you haven't already. Secondly, to talk about prescription drug coverage. And then I have a couple of thoughts about additional descriptive data, or maybe reformulated presentation of that data to help enhance kind of interpretation of the results and some of the policy implications, I think. And then a question about sort of how you're addressing the changes in sample composition. Oh, so sorry, before I go on to that. Yeah, so the first point is this really brought to mind the literature that talks about behavioral health carve-outs in Medicaid, because it's a managed care product that has risk for only a limited scope of benefits. And there's been quite a bit of research on how that maybe relates to care fragmentation and cost shifting to other payers, typically the state that has at that time was the fee-for-service payer. So I thought that might be relevant literature for you to check out if you haven't already. Okay, so prescription drugs. So duals use a considerable amount of prescription drugs, and I was wondering how we should think about the implementation of Part D, which occurred in 2006. And so specifically, are the Medicaid managed care products in 2005 really the same as they are in 2011 and 2012, for example? So like the comprehensive managed care plans, I'm guessing in 2005 were at risk for prescription drug coverage, but I don't know that absolutely. But anyway, I think that might be helpful for you to sort of talk about how this big change in coverage for drugs, which really changed Medicare and Medicaid products, might sort of influence the incentive expectations that you have for the relationship between managed care and hospitalization. And part of that is motivated by kind of a large literature that looks at the effects of changes in drug coverage on management of other types of healthcare use and cost shifting across payers. So just something to sort of to think about. As far as some descriptive data that I thought would be helpful. So what I really wanted to sort of see super clearly was sort of what was the variation over time in treatment status. So for example, for the diff and diff analyses, so that treatment is a binary variable as you described at the county, quarter, and MMC type. And there's a couple of tables and figures within the paper in which one can probably glean this information, but I literally just wanted to know how many turn on each quarter, what's the timing of the variation in each of these programs over time. So that would be, I think, was easy and helpful to the reader. Another thought I had was it's really hard, as you know, to demonstrate pre-trends when you have treatment that is coming on at different time points. And so I thought one possible complement to the set of figures that I think it's 4 through 6, I can't remember which, but might be something like this, where you're showing, again, sort of at certain time points, how many counties are changing their treatment status. And this is fake data, everyone. That's just nothing there on the y-axis. But So just another possible way to sort of portray in a succinct way the trends in the outcome relative to changes in treatment status over time to the controls. Okay, and the last thought about descriptive data relates to policy implications. So as you touched on at the end of the presentation and in the paper, it's relevant to look at the questions you're looking at, even if there's a growing trajectory sort of in the use of more integrated managed care across payers. And so for the reasons you explained in the paper, but I thought it would be helpful to see sort of just descriptively what is the landscape, right? So this is like a snapshot of what's going on in 2012 in terms of Medicare and Medicaid fee-for-service, but what is the landscape now since then, since you really want to try and sort of make relevant to today the results that you're generating from this earlier period. Okay, and the last comment I had was, so as you know, the sample is adults who have, or duals with fee-for-service Medicare. And over the study period, if I glean this correctly from the data, we start with about 94% of the dual population fits that definition at the beginning of the study and 80% towards the end of the study. And because the change is correlated with MMC implementation and characteristics of the population that are changing are related to the outcome, you want to sort of fix that composition. And so the approach, as I understand that you took, was to sort of essentially pick Q4 2012 as like the population composition to hold fixed. And then separately for each quarter, you estimate a propensity score for the probability of sort of being in that kind of group. And so I thought it would be helpful if you could say more in the paper maybe about your rationale for using that particular quarter and for using these quarter specific models to generate the propensity score as opposed to sort of a pooled model. And then additionally, if you could share the degree of non-overlap propensity scores and how that might have varied over time. So, so those are my comments for today, and thanks again for the opportunity to read it.
Great, thank you, Marguerite. This is helpful. I guess, so I will look more into the behavioral healthcare literature. I don't know it very well, but that's a really good point, because I think it's probably similar also to the long-term care carve-outs, right? Where it's kind of this group of services that Medicaid programs have been really reluctant to carve in, maybe because health plans have little experience interacting with these types of providers. So that'll be helpful. For the prescription drug plan changes, so your Medicaid programs were definitely responsible for paying for prescription drugs in 2005, and they're not now, or to a lesser extent now. And I guess I need to dig into the details of whether or not, I know it was common for prescription drugs to be carved out of the managed care responsibilities also, but I should just look in 2005 and see how common it was for the health plans to actually be responsible for paying those costs, or whether or not they were just a carve out in 2005 and paid fee for service at that time, because that is an important policy change that's happening. Thank you for the suggestions on just kind of spelling out the treatment and control counties. I've gone back and forth many times about how to be clear about this, because there's so many different things going on with the mandatory versus voluntary, and then the treatment happening at different times. So those are really useful suggestions, and I'll definitely add those tables in. And then the ideas about kind of spelling out how the landscape of managed care and fee-for-service has changed over time is something that would help put my study into context. So I'll definitely do that too. So thank you. It's all very helpful.
Rebecca, was there any other comment from the chat that you had a time to see that you'd want to address now versus waiting until the author room? Because you'll have an opportunity to address these in just a minute also.
I am looking at them now. I see Rebecca's question. what factors affect a county's decision to roll out and encourage managed care, especially for duals? That's a really good question, and I'm not sure that we understand it. I think a lot of it has to do with the just like the policy environment in the state or the county, and also just like the characteristics of the market. So, you know, are there health plans that are willing to participate in a Medicaid managed care market to cover duals? I think that's the big challenge, and why we see it in metropolitan counties and not in more rural counties. It's just kind of the landscape where health plans are willing to participate.